This is TTT Live. I'm DK Roster. The Ministry of Health is giving an update on the status of COVID-19 in Trinidad and Tobago. We're bringing you live coverage on TTT, Talk City 91.1 FM, Sweet 100.1 FM, Next 99.1 FM, and on Facebook at TTT Live Online. We go now to the Manager Corporate Communications at the Ministry of Health, Candice Alcantara.
Good morning, Trinidad and Tobago. Welcome to the Ministry of Health's virtual media conference on the national COVID-19 response. The members of today's panel are Dr. Roshan Parasram, Chief Medical Officer, Dr. Miriam Abdul-Richards, Principal Medical Officer of Health Institutions, and a new face to the conference, a young medical practitioner, Dr. Andre Earle. I am Candice Alcantara, Manager Corporate Communication at the Ministry of Health, your moderator for this conference. First to address you this morning is the Chief Medical Officer.
Hi, good morning. Thank you, Ms. Alcantara. Dr. Miriam Richards, Principal Medical Officer, Institutions. Dr. Earle, welcome to the Ministry of Health's press conference, members of the media, members of the viewing and listening public. I will go briefly into the clinical update, and then Dr. Richards will take over in terms of the parallel system update, going into the step-downs and the quarantine in more detail. So the clinical update for today, October 7, 2020, in terms of the number of samples submitted thus far, 32,770. The number of unique patient tests completed, 29,664. Number of repeated tests, 3,106. Number of samples which have tested positive will now stand at 4,876. Total number of active cases, 1,782. Number of deaths are now at 84. Number of persons discharged from public facilities, meaning hospitals and step-down facilities, stand at 1,114. Number of recovered community cases are at 1,896. So, if we could go to the dashboard, I would like to introduce the new dashboard and the way we are going to present our press releases from 4 p.m. tomorrow. So as of tomorrow, we'll be having one press release per day at 4 p.m., issued at 4 p.m. to the press. And I'll just go through a little bit of how it will look. So it's a new look. It's a dashboard for COVID-19 for Trinidad and Tobago. We start at the top. Of course, we'll have the date as of 4 p.m. on that particular day. At the top, you see total persons tested. This will include both the public sector as well as the private sector. Unique tests for both places. As you go down the left side, we have total recovered patients, which will be a cumulative total of the number of persons discharged from the public health facilities, plus those who have recovered from the community setting. So it will be a cumulative total, saying the total number of patients recovered. Total number of active cases will be those that are active within the community plus those are active within the hospital. In terms of deaths, of course, that's the total number of deaths per that date. If you go to the right of the screen, you will see new positives reported in the last 24 hours. What you're not seeing on the screen, there will be a little annotation on the bottom which says that this is reported cases, usually representative of what happened over the last 72 hours. In terms of the other graphic where you have a calendar, gives the total number of positive cases for COVID-19 from our first case, March 12, till present. Total number of patients in hospitals represented by an H. As we go to the bottom, we see total patients in step-down facilities. We will give a grand total there. Total in quarantine facilities, those being repatriated, and total persons in home isolation being managed by the CMOH office. We think it's a simpler graphic to follow. There are icons which will resonate with each category. And from tomorrow at 4, we'll be going towards this format of press release. The entire press release, as we now send it out, will also be available on our website so that additional information can be gotten for the step-downs for the quarantine facilities and further breakdowns can be provided in that format as we always did. If we go to I just wanted to go into a breakdown of the community cases that we have so far. And I'll pay a little particular attention to what is happening in one particular county with the largest number of cases, which is County Victoria. So if I can go to my first pie chart, which shows the total number of active cases in the community setting in Trinidad. So looking at the largest county, we still have County Victoria, having 295 cases, representing 25.5% of all the cases in Trinidad. Of course, we go around. If we go to Caroni next, we have 176, which represents 15.2%. St. George West, 138, that represents 11.9%. St. George Central, 13.6%. St. George East, 12.7%. St. Andrew, St. David, 10.9%. Tobago represents 0.8%. Nariva Mayaro stands at 2.9% with 33 cases, and St. Patrick 75%. So in my second pie chart, we'll go into a little more detail with regards to the disposition, current clinical disposition of the cases that are at home, meaning in terms of their clinical status. So if we start at the top in red, we see new cases over the 24-hour period for the country. We had 46 as of this period that we were not, it is not representative of yesterday. I think it was 2 days ago. So 3.7% of the cases were new. Discharges, 2.9%. Those transferred to a facility for whether it be clinical reasons or spatial reasons or socioeconomic reasons, we would transfer to step down, represent 5.1%. Symptomatic at the time with 30%, and 58.1% of those individuals were asymptomatic, being monitored at home. With regards to the County Victoria, if you go to the next slide, please. I believe there's this, if we could go to the other one after this one. Sorry, that's Victoria, yes. So we go to Victoria County. We start at the green at the top. We see new cases representing 3.5% of their grouping. Discharges 2.2%, transferred to facility 7.7%. Symptomatic in that group 23.3%, and asymptomatic being 63.3%. We'll go a little more into detail. Next slide. So we break down in this slide the comorbidities, those with and those without. So the green part of the pie chart shows those with comorbidities, and we'll go into some explanation as to what comorbidities mean later on. Represent 33.2%, which is a very large proportion for any particular county or country. Without comorbidities, 66.8%. And the last slide that I want to show just gives you a further breakdown of our comorbidities within that county. So of the 33.2% of persons that have comorbidities, this is the way it is differentiated and disaggregated. Diabetes 28%, hypertension 34.8%, asthma 6.8%, pulmonary diseases 0.6%, malignancies or cancer 1.9%, heart disease 1.9%, and other comorbidities account for 26.1%. So, Ms. Alcantara, that's my clinical update for this morning.
Thank you very much, CMO. Next, Dr. Richards will get us up to date on the parallel health care system.
Good morning, Ms. Alcantara, Chief Medical Officer, Dr. Roshan Parasram, Dr. Earl, members of the media, and members of the listening public. This morning, I would like to just give you a brief presentation and summary on the changes that have been made in the parallel healthcare system since the first COVID-19 case that was diagnosed on March 12, 2020. The parallel healthcare system is the health sector's response to the COVID-19 pandemic and was operationalized or started on March 12, 2020 with the first COVID case. That patient was hospitalized at the Cora Hospital, and then 2 days later, the Covet Medical and Multi-Training Facility accepted the second patient. Since then, the parallel healthcare system has grown to a 4-level healthcare system with 21 facilities. The parallel healthcare system has been designed to have the following benefits. Firstly, it allows the traditional healthcare system, that is the regional health authorities and our traditional hospitals, to continue their operations with minimal disruption. It also allows the COVID-19 patients to receive COVID-19 specialized care. because COVID-19 patients require a specific type of care which really revolves around intensive care, anesthetics and ICU, as well as internal medicine, pulmonology or chest medicine, and primary care and public health in some instances. The parallel healthcare system also allows a separation of persons with the highly infective COVID-19 virus from those in the traditional healthcare system who may have other more common diseases or comorbidities such as diabetes and hypertension. Lastly, from an organizational perspective, the parallel healthcare system has allowed us to allocate specific resources, human resources, finances, personal protective equipment, laboratory testing equipment, and consumables to this entire system separately. The parallel healthcare system now consists of 21 facilities, and the 4 levels, we look at a system which has a 4-level system. The first level really looks at the care of the very ill persons who are COVID positive, and we have several hospitals within that level. The Cora Hospital, the Covet Medical and Multi-Training Facility, the Arima Hospital in some instances, the Augustus Long Hospital, 2 sites in Tobago, that is the Scarborough Regional Hospital at the Fort and the Scarborough General Hospital at Signal Hill, and the St. Anne's Hospital for psychiatric patients. We also have hospital sites for suspected cases such as the Augustus Long and the Arima Hospital. The next level of care that we look at would be persons who have to go to a step-down facility. That is, their symptoms are not severe but they require isolation. And we have several step-down facilities. At present, we are using the Tobago facility in Tobago and a facility at the Debe Halls. The next level really involves the quarantining of persons, and we have state and state-supervised facilities. The state-supervised facilities, again at Debe, we have 1 facility that we use, as well as the Home of Football, and we have 4 hotels in that process. The changes in the parallel system really have been occurring given the evolving nature of the COVID-19 pandemic. For example, there's been a level of interoperability between the step-down and the quarantine facilities, which can be used for either process. At this point in time, we have more facilities that are being used for quarantine as opposed to step-down because the numbers that are being stepped down are less. As of today, we have 13 patients who are in step-down facilities, which is about 2% of the total capacity. We have 645 beds in the step-down facility with 13 patients, 10 at the Debe facility and 3 at the Tobago facility. The quarantine facilities, we have about 379 beds, and at present we have 182 persons in those facilities with an overall percentage of 48% occupancy. The Chief Medical Officer would have discussed the hospital numbers. At present we have 106 persons in hospital, and when we look cumulatively at the total occupancy of the parallel healthcare system, it is at 22%. The parallel healthcare system has proven to be quite robust because at maximum capacity it reached at about 70% when we had the introduction of community transmission during the month of August. However, given changes in policy and the introduction of home quarantine, we have been able to keep the parallel healthcare system between 22 and 32% over the past 3 to 4 weeks. The parallel healthcare system and its evolution will continue based on the spread of the disease and new information and international evidence that is coming forward on the management of COVID-19. It is material to note that we have decommissioned 2 facilities, that is the Brooklyn facility and Camp Balandra, which was 74 beds, but we have introduced a facility at the UTT Valsin campus, which has given us an additional 150 beds that can be used for either a step-down or a quarantine facility. Additionally, we have allocated 15 beds at the Takrigwa Racket Center for the elderly. So, Ms. Alcantara, this has been my update on the changes in the parallel healthcare system and the overall occupancy. Thank you.
Thank you very much, Dr. Richards. And now we will get a unique perspective on COVID-19 from one of the young doctors in the public health system. We move to Dr. Earl, please.
Good morning. CMO, Dr. Roshan Parasram, Principal Medical Officer, Institutions, Dr. Miriam Richards, of course, Ms. Candice Alcantara, Manager Corporate Communications, and a special good morning to you, the industrious people of Trinidad and Tobago. As said, I am a young doctor, but I am also a COVID doctor, and I am just one of the many dedicated frontline workers fighting day and night to keep this nation, our home, safe. Today, I have been given the privilege of sharing my unique perspective on this pandemic and to bring to your attention that despite the efforts of our hard-working men and women on the front lines, there appears to be equally industrious negative elements in our society, determined to allow this virus to continue to ravage our land and destroy our homes and the lives of our citizens. I received the call to arms in March of 2020, and from then to now, I have seen a resilient people put their heads down, put personal interest aside, and join each other in fighting this biological war. Men, women, and children alike have all made tremendous sacrifices in the interest of saving our peoples from this foe. But there is an impostor among us. It is said that no good deed goes unpunished. And today, my fellow citizens, I want to warn you that in your workplaces, in your neighborhoods, and even in your homes, there are elements that knowingly or unknowingly are seeking to undermine your efforts, my efforts, and this country's efforts in fighting for the lives of its people. The enemy is you. It is me. It is all of us when we let our guard down. We must remember that this coronavirus is unforgiving. This coronavirus does not care about who you are, where you come from, or if you just wanted to take off your mask for 5 minutes because it's making hot and everybody in the office, all his friends anyway. No. This virus will take any window of opportunity to spread and to ravage your body. And it will do so in ways that we on the frontier of medicine are just beginning to understand. Vigilance is critical. That said, to my fellow youth, this virus does not discriminate. It is not an old people's virus, and while we have been focusing on elderly persons as one most susceptible to passing away from this pandemic, this is not just your auntie's virus or your uncle's virus. This virus, if given the opportunity, will cause permanent damage to your lungs, to your heart, to your brain and kidneys and liver, and it will still kill your auntie and your uncle. I understand that the things that I am saying sound harsh, but the things that I have seen are not for the faint of heart. Intubating patients on their hospital beds, running frantically with them to the intensive care unit, seeing the intensive care unit full with intubated patients hooked up to ventilators all around, knowing that people are dying attached to machines with little that we can do to comfort them. My intention is not to frighten you, but it is to stress the urgency of this call to action. The statistics are usually done best by Dr. Hines, but it would be remiss of me to not share the following items with you today. According to a study done in an intensive care unit in Wuhan, China, where we believe this virus has begun, more than 85% of patients developed clots in their legs. In another study in France, in their intensive care units, when they compared very ill persons to very ill persons with COVID, it was found that the very ill persons with COVID, the COVID positive persons, were 3 times more likely to develop what we call thromboembolic complications. What that means is that the blood that usually flows quite well through all of your blood vessels is 3 times more likely to clot. It will clot in your heart and give you a heart attack. It will clot in your brain and give you a stroke. It will clot in your lungs and leave you with permanent lung damage. And to all of the expecting mothers out there today listening to this or watching this, it can clot in your placenta, that organ in your womb that delivers oxygen to your babies. A doctor at King's College Hospital in the United Kingdom, in an interview with the British Medical Journal in May of 2020, said it best. A COVID patient's blood is enormously sticky. According to the Centers for Disease Control and Prevention, better known as the CDC, in the United States, the median age of confirmed COVID-19 cases changed from May to August, beginning with persons that are 46 years old to persons who are 38 years old, with 20 to 29-year-old persons making up the majority of the demographic. In our own wards, we are seeing young people dying or ending up critically ill from the complications of this virus. Imagine how hard it is for a second to call a mother and tell her that her 38-year-old son is dying. My Trinidad family, we can win this war. There are signs that the tide is turning, but we cannot stop now. We can wash our hands. We can wear our masks to cover our noses and faces. We can set an example for our children. And when we lay down in bed at night, we can rest easy, knowing that we have done our best and we have done our duty to our God and to our country. Thank you.
Thank you very much, Dr. Earl. As we move into the question and answer segment of this media conference, we ask our media representatives indicate your name, the media house that you represent, before posing 2 brief questions, please. If time allows, we will accept additional questions. We start off with TV6 this morning. I believe we are ready to go with your questions. TV6, please.
Hi, good morning, everyone. Nicholas Suchman Singh here from TV6 News. CMO, I saw that you compiled some type of data with pre-existing conditions. Could you elaborate a little bit more so that we could actually, because from our vantage point here, we're not able to see exactly what is the leading cause of death for persons with pre-existing conditions. And just furthering on that point, what percentage of patients are surviving after being admitted to ICU and HDU care? And what percentage of positive patients have pre-existing conditions? And a little more on that, how many of them survived with pre-existing conditions? Thanks.
Okay. So thanks for your question. The leading cause of, I think what you're trying to get at is what comorbidities are we seeing in the persons that have died so far? And I suppose the leading ones that we are seeing is diabetes, hypertension, as well as cancer-related conditions in the persons that have died. In a previous press conference, we had suggested that a number of people that have been into ICU and HDU have recovered successfully and are now rehabilitated into normal life. I can get the exact percentage to you all, but it requires some work from the clinicians at Covet to go into the actual notes and pull that data for us. So we can get that to you all at a later time. I don't know if there's any other question.
I think we're fine with TV6, so we have some information for you, okay? Mm-hmm. We move now to 98.1, please. Okay, I'm so sorry, we're not hearing you. I don't know if the mic is muted. Try one more time and see if we can hear you, Mr. Cummings.
Oh, yes. Am I
wonderful
audible now?
Yes, thank you.
Thank you so much. Good morning again to the panel, of course, Ms. Alcantara, CMO, and Ms. Richards, and the other member of the panel. 2 questions quickly. to Dr. Parasram. Dr. Parasram, the Minister, Minister Dayal Singh, spoke on the last occasion of some encouraging signs on our local landscape, with a noticeable drop in cases when compared to recent periods, which showed higher acceleration of discovered cases of the coronavirus. There was a sort of a downward trend line when we looked at the epi curve on a week-by-week basis. I think it was we were looking at some 35% drop. What is the status today? Are you seeing that continuation of that trend? Has there been any major shifts, a tapering off perhaps, as I said, comparatively? And my next question, Dr. Parasram, a status update on the our national flu vaccination drive. Do you believe that we are adequately positioned to fight against what is now being described as a twin pandemic? So we have the flu season and of course the COVID-19 coronavirus in the family of viruses that has sort of created its own problems for us. Thank you.
Okay. So in terms of your first question, there is a continuation of the trends that Dr. Hines and Minister would have alluded to over the weekend. So we are seeing a downtrending again. In terms of the magnitude of it, I will wait a little later on in the week before we quantify what happens for the week previous. In terms of our actual percent, I know they would have said in the region of 32-33% for the week prior. So we are waiting until maybe the end of the week when we can give you an idea of what happened last week. But there has been a continuation of that trend in terms of a downtrending in number of cases. With regards to the influenza update, I know we would have said there's close to 4,000 vaccines that would have been given out over the first 3 days last week of the program, the initiation of the program. Members of the Ministry of Health has been paying visits to the 23 stations that have been giving the vaccines 8 to 4, Monday to Friday. I don't think the way people are coming in is as much as it would have been prior to COVID. So it is something that we have to mitigate against in terms of getting people. And again, once again, we make the call to everyone to come out, especially those persons within the high-risk groups. The health center setting is safe. We have parallel pathways where you can have your vaccine. And those people, especially in the high-risk group, should come out and have your vaccine taken. If you are part of the clinics, you will be reached out to while you're there. And of course, given your vaccine for those who are pregnant, those with chronic diseases, diabetes, hypertension, we'll reach out to you while you're at the clinic already for other treatment and offer the vaccine to you. So it is going along slowly and steadily, but I think the response from the public needs to be a little more robust for us to get the numbers of vaccines delivered to the people as quickly as we can.
Thank you very much, CMO. I-95, we are ready for you. I hope you're ready for us with your questions.
Yes, I am ready for you. Good morning, Candace, and to everyone on the panel. CMO, on Monday, the Tobago reported 5 cases of COVID. However, the Ministry of Health's EM release on that day stated 3 new cases, and in the evening they stated 1 additional case. Yesterday, we were told that 2 of the 5 cases would have actually come from over the weekend. So is it that the 3 cases in the EM report on Monday were from Tobago? And going forward, is there any possibility of including Tobago's contribution to the national report in the new outline as you have it there? And my second question, for persons who are engaged in aquatherapy, apparently they're still having some issues pertaining to the police, so they'd like to find out what documentation they need to have when they're going to aquatherapy in order to convince the police that they're not breaking the law.
Okay, so in terms of what happened on Monday, what happened is Tobago presented their data from a few days previously. The 3 that we represented in Trinidad did not include those that would have been represented before, because we would have been capturing a 24-hour period in terms of reporting. Tobago's numbers are captured will be captured in the dashboard and have been captured nationally as well on our releases, and they will be as part and parcel even in terms of their step down and quarantine facilities when we do our full presentation on our website going forward. With regards to the police, I think you're asking what, in terms of documentation to be presented to the police for aquatherapy? I think it is, was it an exemption that the Minister of Health would have given? If the Minister would have given an exemption, then I suppose that exemption would have been passed over to the police as well, so they would be made aware. So it has to be between the Minister of Health and the Minister of National Security, some passing of documentation to allow an exception to the regulation.
Thank you very much, CMO. And we move to Newsday, please. Newsday, we're ready for your questions now.
Hi, good morning to everyone on the panel. So I have quite a few questions, but my first two are, has the ministry begun contacting people who have not yet received their results since the backlog has been cleared? And two, to Dr. Earl, how does working with COVID-19 patients affect you and other young medical personnel physically and mentally? Thank you.
Okay, so the contacting of patients is a continuous process. As soon as we get those results, they go directly from the Trinidad Public Health Lab to the county medical officers of health. They have a dashboard every day. They contact everyone that they have been notified of any particular result. So that's an ongoing process. It keeps going throughout the day as they get results. So results are presented both via email from the Trinidad Public Health Lab as well as in hard copy. And once they get that at the CMOH offices, they have a team of people assigned in each office to disseminate those results to the public. Dr. Earl, I believe the second question, you can take that one.
Yep. Thank you very much for the question. And so on behalf of all of my colleagues, I think it is safe to say that we are a bit burnt out. The fight has been long. However, the ministry has made our accommodations quite comfortable while we're doing the work that needs to be done. That said, again, we just implore from everyone to do what's responsible and help our numbers decline so that we can help our healthcare workers in turn.
Thank you very much, Dr. Earl. And we move to AZP News, please.
Good morning, everyone. Good morning, Candice. Good morning to doctors. I just wanted to find out from Dr. Richards the reasons for the decommissioning of Cambalandra and the other facility at Brooklyn. Can you say why these and no others you would decommission? You know, what was the reasons for this? And the second question, maybe to the CMO, this whole idea of step-down facilities, CMO, where did this come from? Because is it that the WHO, you know, had given guidelines for step-down facilities, or is this unique to Trinidad and Tobago? Thank you.
Okay, good morning, Prior. Thank you very much for that very interesting question. The Cambalandra facility was commissioned when we had the returning nationals who were on board that cruise ship from St. Martin. And there was a need to find a facility that could have held, say, 68 or 70 persons at the time. The Brooklyn facility was initially commissioned as a step-down facility. Now, both of these facilities were being rented, so there was a cost to the Ministry of Health and, by extension, the government of Trinidad and Tobago. And with time, we were able to use state facilities, for example, facilities that fall under government, such as the University of Trinidad and Tobago and the University of the West Indies. So we actually gave up 74 spaces, 42 at Cambalandra and 32 at Brooklyn, and in turn we have been able to develop 150 spaces at the University of Trinidad and Tobago Valsin campus. So the answer to your question, the decommissioning was based on the reduced immediate need for those 74 beds, and of course the resultant increase in capacity from the facilities, and also as a cost-saving measure moving forwards.
Thank you, Dr. Richards. Dr. CMO, I think the second question for you.
So in terms of step-down facilities, I can't say what it is being done in any other part of the world. We came up with the idea basically to increase the capacity for those patients that were not quite as ill, when we would have had the policy in place where everyone that was positive in the first phase would have been institutionalized in some way or form or fashion, thereby creating an excess burden on the parallel system. So we expanded the parallel system into a non-clinical setting, which was basically step down, where we could do monitoring in a sort of home setting, so that we could at least keep an eye with nursing care, with physicians, with the ambulance service being at the centers, so that if people decompensated in terms of their clinical symptoms, we can take them back to the hospital quickly, but also maintain the hospital capacity in a way that it was actually utilized mainly for persons who were moderately and severely ill. So it was part and parcel of the parallel system by way of treating milder cases before we took the policy decision to home isolate individuals based on the numbers of cases that we were getting.
Thank you very much, CMO. I think many of you all would remember at the last conference we introduced a new segment where we respond to questions that have come to us from the public. And so we go into that segment this morning. First question. It's a very simple question. What are comorbidities?
So, Candice, I would take that question.
Thank you, Dr.
And
Richards.
comorbidities on a whole are really conditions or pre-existing medical conditions that a person may have. So, for example, when we speak about comorbidities in the context of COVID, we are speaking about diabetes, hypertension, we are speaking about lung diseases such as COPD, chronic obstructive pulmonary diseases, and asthma. So a comorbidity is a medical condition, put simply hypertension or pressure, diabetes mellitus, or sugar, as we would say colloquially, and what we would say in the clinics. Thank you.
Thank you very much, Dr. Richards. A second question that we see coming up quite often from the public. What is the recovery period for COVID-19?
Okay, so in terms of COVID-19, we have seen the evolution of this virus. It has been with us less than a year in the world. So again, it is a highly, in terms of research coming back to us, new clinical symptoms presenting itself worldwide, what we have seen is an evolution. In the early days of this disease, we thought it was flu-like, similar to the influenza, where you have recovery of individuals. We thought it was predominantly a lung-related pathology. What we have seen, and Dr. Earl went into some detail with the effects in terms of thrombotic phenomenon that has occurred, and we have seen even in childhood. So in terms of the length of time, there's a new term that has been coined, I suppose, worldwide, in terms of long COVID, in terms of the length of time it takes for someone to recover from COVID-19. What we are seeing is that persons can, what we would have thought, just like any other virus, once you recover in 1 to 2 weeks, you're back to full function. What we are seeing is individuals taking as much as 3 to 4 months to actually recover, if they recover their full function at all. So there are changes that occur in the respiratory system that lead itself to persistent shortness of breath, persistent difficulty with even doing simple tasks, walking up a flight of stairs. And for that reason, we are also seeing persistent fatigue as being a hallmark of long COVID as we see going forward. We expect to see, as the research continues and the number of cases increases worldwide, that additional symptomatology as it relates to long COVID and the clinical course of disease will only be proven in time in the months and years to come. So we want to introduce the concept of long COVID to the public. Next week we hope to have someone, we are establishing a unit within the North Central Regional Health Authority through the RHAs where persons can undergo respiratory physiotherapy who have recovered from COVID, and there's a particular unit under Dr. Trotman that will be established hopefully soon. And next week we should have someone in from that unit to talk about a little more detail about what is long COVID and how we treat it going forward.
Thank you very much, CMO. And the last question from the public. What are the recommended precautions for isolation at home, especially for those persons with large families or living under one household?
Okay, so there are a number of things on the website. We have the home isolation guidelines, which have been distributed via the CMOHs as well. So basically we're speaking to the normal precautions that we take. So if someone is ill, we expect that person with COVID to, of course, wear a mask at all times if possible, maintain a separate room if that is possible again. Difficulty in terms of having separate spaces often occur. People may have one bathroom where they have to share. We expect that sanitization before and after occurs, as well as ensuring that there's no sharing of utensils in terms of persons using the utensil who is ill and then someone who is not ill using the utensil prior to properly sanitizing and washing those utensils. So again, on the website, there's a full detail as to how to home isolate. If, of course, as I said, there's socio-economic or there's spatial challenges in a home, through the CMOHs who are following you up for COVID-19 and calling twice a day, you can indicate to those individuals that you're having difficulty isolating, and we can bring you to a step-down facility or hospital for the duration of your isolation period, so that at least your family and loved ones can feel safer that they won't be at risk of contracting COVID-19.
Thank you very much, CMO. And we continue with questions from the media. And we're ready now at this time for questions. I'm so sorry. We continue now with our questions from the media. And we go now to 91.9, please.
Hello, good morning, everyone. Good morning, doctors. Vern Extavor, 91.9 FM. CMO, if we could get some information, has there been any information to support some of the non-clinical measures, especially put forward by persons who are in the field of that non-traditional medicine, the herbalists and that kind of thing, in terms of encouraging people to build immunity and offering some other, solutions with respect to increasing their vitamin D in particular? Has there been any scientific evidence to prove that some of these particular methods could work, that people should focus on improving their immunity, building their vitamin D? Are there any specific measures for people who want to just safeguard themselves by building resistance to the virus? And also, in terms of persons with comorbidities, has there been advice specifically put out for persons who have things like hypertension and cancer, just simply not to move around or not to go to work? A lot of people still have the fear that simply because they have some comorbidity, they just don't want to interact with the public. They've been isolating themselves, not going to work. Some cases, some have had to leave their jobs. What kind of advice are you giving to persons with comorbidities living in this time of COVID-19? Those are my two. Good morning.
Thank you. We go to Dr. Richards for a response.
Hi, good morning. Some very topical questions that you have posed to us. So the first question that involves the building of immunity through non-traditional or non-Western medicine practices, I'd like to address. The Ministry of Health prefers to proceed in terms of the guidelines from the World Health Organization and international evidence, which suggests that the suggests the spread and the transmission types of the COVID-19 virus. So our recommendations are in line with World Health Organization guidelines based on international evidence, and really speak to all the measures to reduce contact, and really in terms of social distancing, proper hand washing, sanitization, and so on. The second question spoke about comorbidities or other medical conditions such as hypertension or high blood pressure, diabetes, and cancer, and what sort of advice should be placed for such persons. The advice for the reduction or to reduce the risk of you developing COVID-19 or contracting the virus is the same to everyone. It applies across the board to persons who have these medical conditions such as high blood pressure and cancer, as well as those who may not. Simply being, the reason being that persons who do not have these medical conditions are in contact and in close, communication. For example, a parent in a home may have these medical conditions, whereas the children or a sibling may not. So given that sort of interaction in a home, we strongly advise that out of an abundance of caution, all of the precautions that have been highlighted by the Ministry of Health and that are highlighted on our website and our social media pages, and which the CMO has been explaining since the beginning of the pandemic, need to be adhered to by everyone. Thank you.
Thank you very much, Dr. Richards. And we move now to Express newspaper.
Good morning, Kim Mojang from the Express. Thank you, doctors. CMO, I'm sorry, I'm having a little
Yes, you seem to be having a little issue with your audio. So what we will do is try to see if we can clear that up and come back to you. Alternatively, you can send in your questions, please, Ms. Budram. And we move to some repeat questions. CL Communications, we're going into the stage now where we ask for one brief question, please. CL Communications, we're ready for you, please.
Good morning. I just wanted to find out when it comes to the Balandra and the Brooklyn centers, what does it cost this country to stay open? And I just wanted to find out too, when it comes to confidence in the health sector, do you think the public now has a general sense of more confidence in the health sector and health professionals in this country? Thank you.
Okay, I think Dr. Richards will take the first question because we're just going with one question this round, please.
We can confirm with you in a subsequent update the cost for the Balandra and the Brooklyn health facilities, because the cost would not have just been a simple measure in terms of a rental, but it would also include other facets such as the human resources that were needed, the provision of consumables and so on. So through the Office of the Chief Medical Officer and the Corporate Communications Department, we will endeavor to have that figure presented to you in an accurate and transparent fashion in the very near future.
Thank you very much, Dr. Richards. And we go now to I-95.5, please.
Thank you very much. Good morning again. CMO, the number of repeat tests as outlined in the reports daily, those numbers would have essentially been marking time now for over a month, but recently we saw an uptick in those numbers. Can you say what the reason for that is, and also to confirm that the terms pre-existing medical conditions and comorbidities are used interchangeably?
You want to take the second one? Second part? Go ahead.
So I'll start with the response to the second part of the question. And yes, we sometimes use the terms comorbidities and pre-existing conditions interchangeably. And as I reiterated earlier, we are really speaking here about high blood pressure, hypertension, diabetes, mellitus, cancers, asthma, chronic obstructive pulmonary disease. Thank you.
Thank you very much. And we go to TV6, please.
Good morning. Good morning, everyone. Once again, Nicholas Suchman Singh from TV6. I know Dr. Earl will have spoke on behalf of doctors, whether they are being burnt out or not. But can anyone give an update on whether nurses are being burnt out right now? Because we're hearing complaints from patients that they're not getting adequate care from nurses at times, not all nurses, but some at times, as it seems that some nurses are being burnt out or unwilling to do extra things. So could anyone speak on that?
Well, we'll be happy to if you could off air give us the complaints that you have heard of. We'll try to address those concerns. But I mean, we can't seem to attribute any of those behaviors to burnout or that scenario without knowing the specific details of what has transpired. So if you can get those details, we'll certainly look into it and get back to you.
Thank you very much. And a follow-up question now from Newsday, please.
Hi, good day. Paula Lindo here from Newsday. Just a clarification. My colleagues would like to find out whether the number of 295 for County Victoria is a percentage of the current active cases. And also they're saying that the figures presented in the pie chart are adding up to 101%. So if we could get some clarity on that, please.
Correct. So the pie charts that I presented is not from today. The pie charts would have been generated a couple of days ago. So we would have had, as you noted, some additions, and then we would have had some discharges. So the numbers will be slightly different from what you are seeing today if you use today's figures. So the numbers will be different. All right?
Thank you very much. And we got the question from Ms. Budram from Express. And this goes to CMO. There are many persons who are facing their first winter abroad, nationals who are waiting to come back home, and they are quite anxious.
Okay.
They're older or may have health issues. Has the ministry received any such concern, and is there any recommendation to increase repatriation for such categories of persons in the coming months?
So the matter of repatriation has and always lies with in terms of the exemption process with the Ministry of National Security. So again, those instances, if you have persons that you know of, you can send that information to us or to Ministry of National Security directly.
Thank you very much. And I see we have another question from CL Communications. We go to CL Communications at this time, please.
Hi again. Are you hearing me?
Yes, we can.
Okay, so basically I wanted to find out how many more young doctors are spread across the health sector, and do more experienced doctors work alongside with them? What is the procedure when you put young doctors in health institutions throughout Trinidad? And I didn't get this question answered. Do you feel that people are more confident about the health sector now, given the COVID response that I've within the last few months? Thank you.
So I don't know if your question relating to young doctors, the definition of youth being different throughout the world. Someone who is old is above 60, all right? I think we use the term loosely in Trinidad, young doctors. I think we're talking about stages or levels of care or levels of clinicians. So in our system, what we have are interns who are graduated doctors who are going through a 1-year period of internship, where they are usually meant to work alongside other individuals. Once you are house officer level and above, through the Medical Board of Trinidad and Tobago, you are supposedly able to work on your own, and you're given a full certificate of to discharge your medical capabilities. However, in the truest sense of what we describe as junior and senior rather than young and old, junior doctors being defined as house officers and interns, senior doctors being defined as registrars and consultants. So registrars and consultants in most instances have some subspecialty that they have undergone, and the consultants normally supervise a team of doctors that would have registrars, house officers, and interns accompanying. There would not be someone with the skill set that doesn't have the skill set that is required to function in a particular environment. For example, in a neurosurgical environment, we won't put a junior doctor alone to deal with a particular patient. They will have senior coverage, as we call it, in the medical field. So they will have a registrar or consultant overseeing what they're doing at all times.
Thank you very much. And I see 91.9 has another question. Mr. Extevor.
Thank you very much. Good morning again to everyone. Just one final thing. Dr. Parashram, you did mention that there will be some rehabilitatory clinics, that you are seeking to start for persons who are recovering from COVID-19. If you could just give us a little bit of a better idea about some of the things people may expect coming out of COVID, what you've seen so far. I know it's very new and we don't have specific data, but based on what we've seen, and maybe Dr. Earl could probably contribute to that as well in terms of what persons who are recovering from COVID-19 could expect to face as continuing symptoms or risks that may, they may be susceptible to after the virus. If you could give us some information on that, that'd be helpful. Thanks. So
the two main things that we have seen in Trinidad, at least, and documented in the evidence, are persistent shortness of breath and persistent fatigue, which have gone on for a considerable length of time after recovery. And those are traditionally in persons that would have had comorbidities or persons that would have been in a high level of care, for instance, HDU, ICU settings. So those are the two main ones that we have seen in our country and in other parts of the world. Again, it is something that is evolving, as you said, and only as time progresses we will be able to properly define what are the symptoms of long COVID as we described it. But again, those are the two main ones that we have. So shortness of breath and persistent fatigue is what we are seeing. Those that would have had thromboembolic events as a result of COVID, or because they had pre-existing conditions which were worsened from COVID, for example, you would have had a heart attack or a stroke. Of course, the rehabilitation pathways will be along the lines of those particular illnesses as well. So again, you'll get persistent weakness, fatigue, shortness of breath. And of course, if you have past a stroke, you have the certain intricacies, for example, left-sided weakness or some persistent weakness. You can have those specific areas of deficiencies going forward based on what has happened as a result of COVID.
Thank you very much, CMO. And we have come to the end of this morning's media conference. Just a reminder to members of the public, starting tomorrow, the Ministry of Health will send one simplified release per day, and that will be sent at 4 p.m. Additional information will be available on the COVID-19 page of the Ministry of Health's website, www.health.gov.tt. One release at 4 p.m. starting tomorrow. Everyone have a good day, be safe, and of course, wear your mask.
As a father and a husband, I believe it is my role to protect my family. As a Trinbagonian, I also have a responsibility to my fellow men. We can't protect our loved ones and our country from COVID-19 if we all wear a mask over our nose and mouth in public, stay at least 6 feet away from others, stay home, especially if we are ill, wash our hands often with soap and water and use a hand sanitizer, cover our coughs, avoid touching our face, and clean and sanitize the surfaces that we touch often. Everyone must do their part. This is why I follow the new normal.
A message from the Ministry of Health.
I don't know what's wrong with Gladys, you know. I don't know. She jumping up and down and carrying on like she's a crapo, like a carnival. She said it's because of the hand sanitizer, because it's 60% alcohol-based.